Hi, Michelle.
Hello.
So I think it's being live streamed and it's being
Yes.
recorded, right?
Yes.
You can start once 5:30.
Yes.
We have 2 more minutes, I think.
Good evening, sir. Akshay, sir.
Good evening. Hi. Good evening, everyone.
Hello, Michelle.
Hello, sir.
Hi, sir. So did you share in your Chennai groups about this meet?
Yeah. I put it in our Apollo Hospitals group and our local Ortho Society group also.
Okay.
Hi everyone. Hi Michelle. Hi Dr.
Hello,
Akshay.
sir. Hello,
Hi
sir.
Vishnu.
Hi, Manish.
Hello,
All good?
Yes, sir. All good.
Okay, so it's 5:30 already, I think. Shall we start?
Yes, sir. Yes, sir. We'll start.
Yes, please start. Thank you.
Great. So I think Sarcoma Education Foundation needs an applaud for this attempt at educating the young orthopods and also the general orthopedic practitioners to educate them in whatever there is to and there is not to be done in treatment of bone and soft tissue tumors. And biopsy, as we all know, is a very sensitive topic. We know that, Mankin found it a problem in 1982. He again found it a challenge in 1996 when the errors in making a decision and a treatment were manyfold higher if the biopsy was done in a referring center rather than in a treating center. And unfortunately, that remains a problem even today. And believe you me, each one of the faculty that is there on this panel keeps having these problems where, these patients, just because of a wrongly done biopsy, need to undergo a procedure that is more morbid, or a procedure that costs them a lot, costs them much more than it would have, and sometimes even cost us the limbs and lives of these patients. So we all know how sensitive a topic is biopsy. And my advice to all the young colleagues who are attending is that if you are going to be an orthopedic oncologist, please do learn the details of doing a biopsy very carefully. And if you're not going to be an orthopedic oncologist, you should learn it all the same, because the reality of our system and society is that probably biopsies will be done by orthopedic oncologists as well as orthopedic surgeons who are not in specialty orthopedic training and practice. It's an honor to welcome a very august, a very illustrious faculty with us, and I will leave the privilege of introducing the faculty to you by my co-moderator, Dr. Michelle, who is the force behind this session of Nurture the Future. Michelle, over to you. Please carry on.
Thank you, sir. Thank you. So, to start with this session on biopsies, we have Dr. Vishnu, who is a consultant orthopedic oncosurgeon in Apollo, Chennai, and he would, throw some light on how to do a bone biopsy. Sir, over to you, sir.
Thank you, Michelle. Can you allow me to screen share, Michelle, please?
Yes.
Your screen sharing.
So now you can do this.
No, it's still showing that you're screen sharing.
Sir, please try now.
No, it's still not. I'm not able to share. It is only showing desk. Am I now visible
Yes.
and audible?
Yes, sir.
At the outset, thank you to the Sarcoma Education Society for giving me the opportunity to speak on biopsy in bone tumors. We'll start with a case scenario to show the importance of biopsy. This is a 30-year-old male patient who had pain and swelling over the right knee for the past 2 months. This was the radiograph, which showed a pretty innocuous looking lesion, a lytic lesion in the metaphysis of the distal femur. Uh, the patient had undergone an MRI also, and on the MRI they had suggested a diagnosis of giant cell tumor based only upon the imaging. So this patient underwent a open surgery with curettage and fibula bone grafting, and this is what has happened to the patient in the next 4 months. Over the next 4 months, and the biopsy, the open curettage which they had done, turned out to be a osteosarcoma, where you can see neoplasm composed of spindle cells and well-formed bony trabeculae. So the curettage specimen was of a osteosarcoma. Now we redid the biopsy because it was a 4-month-old biopsy which confirmed a high-grade osteosarcoma. Once a diagnosis is established, staging investigations are required, which is a CT chest and bone scan in this situation. And unfortunately, the patient had to undergo an amputation in view of a bulky tumor and severe pain. This is another similar scenario where a pathological fracture was found in a 65-year-old male patient, and the orthopedic surgeon has gone ahead and done a nailing. At the time of the surgery, they did the reamings, which was sent for histopathology, which confirmed a primary leiomyosarcoma of bone. Now, a lesion which could have well been managed with just an intercalary resection now required a total femur resection, which completely altered the management of this for this patient. Now, how to avoid these disasters? Always, this is a flow chart which tells you about the evaluation of a patient with bone tumor, and always age is the single most important criteria to establish a diagnosis of bone tumor, where patients who are above 40 years should be evaluated in terms of a Mets myeloma, and always prior to doing a biopsy, an MRI is required. Now, what is the role of the MRI? The MRI will evaluate the entire length of the bone, including the adjacent joint. It will evaluate for skip metastasis. It shows us the proximity of the tumor to vascular structures, and it is occasionally helpful in diagnosis of certain bone tumors by experienced radiologists. It's important to take the full length of the bone. As you can see, skip mets can be missed if only a limited MRI is taken. Now, coming to the bone biopsy proper, what are the options that are there? We have got needle biopsies. Needle biopsies have got a 90% accuracy in determining malignancies. It has got accuracy in determining the specific tumor much lower, and the absence of malignant cells is less reassuring than incisional biopsies. You've also got core biopsies, which provides accurate diagnosis in 90% of the patients, and you have of course got open biopsies. So this is the flow chart which is showing the type of biopsies. You have got needle and open biopsies. Needle biopsies can be a FNAC, which is a fine needle aspiration cytology, or a core needle biopsy. And FNAC has got no role in the primary diagnosis of a bone tumor. FNAC is usually reserved for suspicious lymph nodal metastasis or to prove recurrences. So what we need to do is basically a core needle biopsy here. So the core needle biopsy, you can do one of two things. You can either take a true cut needle, and if the mass is having a lot of soft tissue component, you can take a soft tissue core needle and take the biopsy from the soft tissue. Or if you have to take it right from the bone, we use what is known as a Jamshedi needle or a J needle. Coming to open biopsies are of two types. They can be incisional biopsy or excisional biopsy. Here I want to stress that there is very limited role for excision biopsy in bone and soft tissue malignancies. It is usually reserved only for those patients who are having tumor size around 3 centimeters or superficial tumors. Only then excision biopsy is advised. Otherwise, all patients we prefer to undergo biopsy with a true cut needle. So this was a paper from Singapore which concluded that a core needle biopsy is accurate and a reliable tool for musculoskeletal tumors, and the sensitivity of a core needle biopsy is around 90 to 95%. So as told previously, the role of FNAC in bone tumors is very limited. It is usually confined to detection of recurrences and lymph node based FNACs. Now the next question that needs to be answered is who should do the biopsy? The biopsy is always best performed by the surgeon who will be doing the definitive surgery, or under his guidance through a radiologist. As Dr. Akshay had told us, this was founded after a study by Mankin et al. In 1996, where he told that the change in course of outcomes or the type of surgery needed were 2 to 12 times greater when the biopsy was done in a non-referral institute instead of the treatment center. So these are examples of poorly performed biopsies. Here you can see in the first picture, they have gone anteriorly through the patellar tendon, which means the entire patellar tendon or the extensor apparatus is contaminated. Similarly, in this, a distal femur lesion has been biopsied right through the rectus, to the rectus femoris, which is again contaminating the extensor apparatus. This is another example of a distal femur lesion where a biopsy is done from the posterior side, which is the non-conventional side for doing the biopsy. This patient would have probably benefited if the biopsy had gone through the lateral condyle here. So why is this positioning of the biopsy important? Because it is important in bone and soft tissue tumors that the biopsy tract be excised with 2 centimeters margins all around, because it is assumed that the biopsy tract is seeded by microscopic tumor cells. Here are a few more inappropriate biopsies. A metaphyseal lesion where a large open biopsy was done through the rectus. This is a common thing which we face in humerus, where orthopedic surgeons are comfortable with the deltopectoral approach and they do a deltopectoral biopsy for proximal humerus lesions, which is not the correct plane to go. Also, putting multiple incisions like this while doing an open biopsy is definitely should not be done, because this entire area will now have to be removed and the patient will require a very morbid surgery with flap placement. Now, before we do a biopsies, there are certain lesions which are known as touch me not lesions or don't bother me lesions. These include bone island, small enchondromas less than 3 centimeters, non-ossifying fibromas here, which you can see, and intraosseous ganglion cysts. These are tumor-like lesions which can be diagnosed just on the X-ray, and these are don't touch me lesions and need not be biopsied, as the diagnosis is established only through X-rays itself. Now, if we are doing the biopsy, we need to assess which part of the lesion has to be biopsied and what is the safest anatomical route for the biopsy. We should not hesitate to ask radiologists for assistance. Now, where should you biopsy from? Now, normally the central area of the tumor is necrotic, and the peripheral area is the one which is the actively growing area. So our targeted area should be in this periphery. So if you can see, this is the X-ray of osteosarcoma of the humerus. Here you can see the central area is completely necrotic. It is completely white, filled with liquefactive necrosis, and the darker area which is surrounding it is actually the representative area, and the biopsy should target this area. Similarly, for soft tissue lesions, here you can see this is a cystic area which is completely filled with fluid. So if you biopsy from here, the chances of you getting representative tissue is less. So you need to choose the solid areas which is shown here, and this is why an MRI is mandatory prior to doing a biopsy. So where do you do the biopsy from? For the common sites, this is for proximal humerus, you should avoid the deltopectoral approach and you should go through the anterior fibers of the deltoid, which is so that that entire tract can be removed along with the deltoid muscle. Next, for distal femur, we usually prefer an anterolateral or anteromedial approach, where your needle tract is going either through the vastus lateralis or through the vastus medialis. We should try to avoid going through the rectus. Similarly, if the patient is planned for any intercalary resections, we prefer to do the biopsy from the lateral side. For medial side lesions, you go through the vastus medialis. Proximal femur lesions are better biopsied through the lateral side. Proximal tibia lesions, depending upon the location, can be either anterolateral or anteromedial. So in this case, probably we'll have to go laterally. And in the case on the right, we'll have to go medially. So basically, the entire idea is in the tibial lesion, it's better to go through along the subcutaneous border. If you have to go laterally, it is better to go through the tibialis anterior rather than contaminating multiple sites from here. So what are the principles of doing the biopsy? A biopsy is done only after evaluation and imaging is complete. We have to determine the characteristics and the local extent of the lesion, as well as assess the metastasis sites, because the staging also will determine the exact anatomical approach to the tumor. So we need, if we are doing open biopsies, we need to place very small incisions. The biopsy tract should be considered contaminated, and this tract needs to be excised en bloc along with the tumor. The surgeon should be familiar with incisions for limb salvage surgery and also with standard and non-standard amputation flaps. Now, for open biopsies, if a tourniquet is used, we should only elevate the limb and we should avoid exsanguination. We should contaminate as little tissue as possible. So hence we should avoid transverse scars. The deep incision should go through a single muscular compartment. Neurovascular structure should be avoided. We should not raise flaps or so that it is not contaminated, and minimal retraction should be there to limit the soft tissue component. If a hole has to be made in the bone, it should be made round or longitudinally oval, because if you don't do like that, there's a higher risk for fracture. If a hole is made large hole, you can use PMMA to plug it so that the hematoma will be minimal. A biopsy should be taken from the periphery of the lesion, which contains the most viable tissue. So this is an example of a round hole which is made in bone. Now the question that actually arises is, when should you do an open biopsy? Normally in our practice, we try to do the first step for a easily palpable lesion is to do a needle biopsy. If a needle biopsy fails, the next step is to do an image guided biopsy. For palpable lesions, it may be ultrasound guided. For non-palpable lesions, it may be CT guided. Once this image guided biopsy also does not show representative tissue, it is only then that we proceed with an open biopsy. Usually when we do an open biopsy, we do send the sample for frozen section because the patient is under anesthesia, so we can ascertain whether we have taken representative tissue or not. Drains usually we don't use. If a drain must be used, it should exit in line with the incision. And we should avoid putting poor drain sites like this, because the drain site also will have to be excised along with the open biopsy scar. So what are the advantages of a needle biopsy? The needle biopsy causes very little tissue contamination. It produces a small surgical scar which is easily excisable. An image guided option is there. It's an OPD procedure done under local anesthesia. Short procedure time of only a few minutes. Much lower cost, and it's easily repeatable. Disadvantages is that a technical disadvantage is the small area sampled, but with the technique that we will show you subsequently, you can see how you can get good tissue. If sometimes they say that reliable grading may not be possible because tumors tend to be heterogeneous. Coming to open biopsies, the advantages are that you will get adequate tissue, including tissue for immunohistochemistries, and the grading may be more accurate. However, it is more invasive with significant contamination, thereby increasing local recurrence rates. There may be skin loss during definitive surgery, which will cause problems in wound closure. It's an OT procedure requiring anesthesia, leading to higher costs and a longer recovery time. For doing soft tissue biopsies, we use what is known as the gun needle. On the left is the barred gun needle, and on the right is the true cut needle. A barred gun is a mechanical device which will shoot this out actually. This is an example, video example for a lesion in the distal femur. Here you can see a patient with a lesion involving the metaphysis with a large posterior soft tissue component. So this is the video of the biopsy. We usually mark out all the areas which have to be important landmarks, including the patella tendon and the quadriceps. We have marked the joint line also here. So as I had told you earlier, for a distal femur lesion, we need to go either medial or lateral through the vastus. In this case, we are going through the vastus medialis. This is the J needle. It consists of a trocar and an outer cannula. The trocar has got a cutting core. So when you want to make a hole in the bone, you use it with the trocar. So you make a small stab incision with a 11 blade. You push the trocar inside. Once you are inside the bone, you need to remove the trocar outside. Now inherently the J needle has got a cutting core. So when you rotate the needle in a single direction, in one direction, like you can see here, I am moving it clockwise. As it moves inside, it will take out a core of bone into the sheath. So give slight negative suction on the J needle so that the bone piece remains trapped inside. Once you take it outside like this, you can just push it with the trocar again, and you can see here a lovely, nice big core of tissue comes out. So you can take multiple cores. The important thing to note is once you have made the hole in the bone, when you are putting the J needle in the second time, you should ideally go back into the same hole. And once you are inside that hole in the bone, you can change the direction so that you can get more representative tissues from different portions of the tumor. We usually send the sample in 20% formalin as shown here. Thank you.
Thank you, sir. Sir, so there are a couple of questions on the chat box, and one is
Yeah,
in the upper end. Yes, yes.
Yeah, please tell me, Michelle, which
So the one is
so there
upper end.
is a question. Yeah, there are a few questions. Can a biopsy done without can be done without doing an MRI? No, an MRI is mandatory to do a biopsy. A CT scan is not adequate. An MRI will show you areas of necrosis as well as the solid areas which are present in the tumor, so that you can actually target the solid area while doing the MRI. Open biopsy will give me more tissue, so why not do open biopsy and help the pathologists? No, the problem with doing an open biopsy is you are contaminating more tissue. So while you're resecting it, the amount of skin loss will be much more. And in some situations, like in proximal tibia, you might actually end up putting a flap, which could have been avoided if a needle biopsy was done. So another question is upper end of tibia biopsy approach. Please explain again. So ideally for the tibia, it is best to go along the medial subcutaneous border of the tibia. However, if the tumor is present more on the lateral side, like it was shown, it is better to go slightly anterolaterally through the fibers of the tibialis anterior rather than go further lateral, where you will contaminate the extensors also. So for proximal tibia, ideal to go on the medial side along the subcutaneous side, and if you have to go laterally, it is better to go slightly anterolateral through the tibialis anterior. There's another question: why cannot exsanguination be done before tourniquet while doing biopsy? So there is a risk that while doing exsanguination, you are actually pushing tumor cells into the bloodstream, and hence exsanguination is not advisable to be done. Also, while doing the exsanguination, because the bone is weak from the tumor, you might actually cause a pathological fracture, which makes a lot of problem. Now, what is a punch biopsy? A punch biopsy is usually done with a punch biopsy forceps. So it is usually done for cervical cancers. There is a punch biopsy forceps which comes, and you can usually use it in musculoskeletal. We use it for squamous carcinomas and melanomas or skin tumors, where you can just put this needle, this punch biopsy forceps, which looks kind of like a Chittle's forceps, and it will take out a punch of tissue from the edge of the tumor. Punch biopsy forceps is normally routinely used for doing cervical biopsies, and in musculoskeletal we use it for squamous carcinomas. Last question is it necessary to finish all the staging studies before doing a biopsy? Now, there is little controversy in this. My suggestion is, if you see a suspicious lesion, I would do a biopsy first, because my staging investigation is going to be decided on what biopsy report I get. For simple example is, like for example, if you are suspecting a giant cell tumor and we do a staging CT chest, it is of no use. So we have to kind of balance this. So I would suggest to do a biopsy first, followed by staging. This is little controversial, but I would still suggest, especially early on in the career, you cannot go wrong if you do a biopsy and then stage the patient. So what is the target area in pathological fractures without significant soft tissue? So again, for a pathological fracture, you should do an MRI first. The MRI will tell you where the fracture hematoma is actually, and it will show you inside the bone where the solid component of the tumor is. You can actually you do a needle biopsy, you can enter through the fracture site itself, because already a ready-made hole is there in the bone, and target that solid component which was shown to you on the MRI. Next question is, please tell the approach for humerus, femur distal end and proximal end of the radius. So for the humerus, the most important thing is avoid going deltopectoral. You're supposed to go anterolaterally through the anterior fibers of the deltoid, because the deltoid muscle is taken out in proximal humerus resections as margin. Now for femur, you either go medially or laterally. That is, if you're going medially, you're going through the vastus medialis. If you're going laterally, you're going through the vastus lateralis. You should avoid going through the rectus femoris. For proximal radius, again, depending upon where the location of the soft tissue component is, the safest place to go for a proximal radius is through the dorsoradial approach, where you're going through the mobile vad of Henry, which can be excised along with the tumor. I hope I've answered all the questions.
Yes, sir. So we'll go on to the next talk. And the next talk would be, what to avoid during the biopsy. And I shall, share my screen. Yeah, is it visible?
Yes, Michelle.
Yes, Michelle, it's
Yes, sir.
visible.
Yes, sir. So this previous talk by Dr. Vishnu was excellent, comprehensive, and it has also covered most of the points that I would want to cover. But again, it is just a reinforcement because, like Dr. Akshay Tiwari also said in the beginning, that biopsy is the most important step in the complete treatment of a musculoskeletal tumor. And what to avoid during a biopsy? So there I have divided into three parts. It is pre-procedure, that is probably the planning part. We've already discussed why imaging is required and what kind of imaging is required and why. Before you plan your biopsy, you should have your full length X-rays in two perpendicular planes, all sequences of the MRI in place, so you exactly know that what is going to be your approach and what is the area that you have to target during the biopsy. Second thing is never miss out the relevant blood investigation. Now this is sort of very simple, but sometimes very significant. People who are on blood thinners, your simple incision can make them bleed a lot. Since most of our biopsies are done in OPD based procedures, we don't have backup if there is a massive blood loss during biopsy. Triple H is your viral markers. Again, you have to be safe. Universal precautions have to be in place. Sometimes we have a biopsy period where we do all biopsies together one after the other. So you don't want your first patient to be seropositive and your other patients suffer. And again, do not do it without an informed consent. Sometimes, in a heavy, busy OPD in specialized centers, you just send the patient to biopsy and the patient doesn't know what is exactly going to happen. You put in the local anesthesia, do the biopsy, and sometimes they said, no, I don't want to get it done. So these are some very simple but important points before you do a biopsy that inform the patient what is going to happen, the pros and cons, and then take a decision. Now, peri-procedure, like this was already discussed, it has to be in a very sterile, condition. You have to prepare the part adequately. Draping has to be done, and then you proceed with the biopsy. You can also do it under local anesthesia in an operation theater setting. We require a CIAM for better visualization of the lesion, which is not very palpable outside. And pain threshold of the patient. Now we are used to doing it in OPD setup under local anesthesia, but sometimes these biopsies can be very painful if we have to enter the lesion through some hard or normal bone, and these patients cannot tolerate the pain and the procedure itself becomes very messy. So be aware that sometimes sedation or short GA is required for these patients, especially for pediatric patients less than say 12 years of age. Even though it is a very superficial and a sort of a lytic cystic lesion, you still undergo this procedure under short GA or sedation. Heparinization. Now, what is this? When you are preparing your J needle for a biopsy, I would suggest that the saline has to be heparinized and the needle walls from inside have to be flushed with this heparin, so that when you put in the needle in the body and there is some sort of bleeding, the blood clot doesn't make the actual tissue that is being biopsied left behind in the patient's body only. The blood clot will occupy the needle space and the core that you get will be left behind while you are retracting your needle. So heparinized needles is what is to be done, and adequate hemostasis. So even after a needle biopsy, there is little bleeding from the tumor or from the incision that you have made. Apply pressure, wait 2-3 minutes for the hemostasis to occur, because when this hemostasis doesn't occur and there is bleeding from the lesion towards the skin, you get a bad hematoma. It is also contamination or seeding of the disease into the superficial skin, and you may require a flap when you go ahead for a final surgery, considering the contamination the hematoma has formed. In open biopsies, like Dr. Vishnu also said that we would want to avoid an open biopsy unless multiple needle biopsies and image guided biopsies have failed to achieve representative tissue. In today's time, in trained hands, this is very less and very rare. Literature also says that more than 95% accuracy is achieved with a needle biopsy which is well planned on the imaging that is in hand. Now, in case you have to do an open biopsy for whatever reason, do not go through compartments. Like in orthopedics, we always have our compartments. The commonest example is the proximal humerus, which was discussed, deltopectoral approach. Do not go through the deltopectoral approach, go through the anterior fibers of the deltoid because that has to be excised. So this is what is the pictorial description. Do not do intercompartmental planes. Avoid neurovascular bundles because the contamination around the neurovascular bundles can lead us to do amputation rather than the limb salvage surgery. And avoid use of tourniquet. The reason for this is that when you are doing an open biopsy under tourniquet, you might miss out the bleeders, your hemostasis may not be adequate, and then when you release the tourniquet, it will be very difficult to catch those bleeders which are bleeding, and during the procedure you might have to open more and then contaminate, raise flaps, etc. Again, this is an example of how to avoid a neurovascular bundle. The lesion is in the proximal tibia posterior aspect, but you will not go posterior. You will go from the directed approach that we have, that was the anteromedial approach that was discussed. This is what we prescribe when we are doing an open biopsy and you are making a window. Do not make a square or a quadrangular window, make a rounded edge window so you avoid the chance of a pathological fracture. Again, do not take transverse incisions because the transverse incision will lead to a flap requirement during the final surgery because the scar of the biopsy has to be excised. Do not enter through joints when you're doing open biopsy. Do not contaminate the joint because your resection then becomes difficult because you have to excise that joint as well, and it becomes an extra-articular resection rather than osteoarticular resection. Do not raise flaps again for the reason of contamination, and I discussed before that the drain has to be in the line of the incision because when the final surgery is going to be performed, even the drain site has to be excised with the scar of biopsy. Now, after biopsy, what should you not do after biopsy is use of traumatic instruments to transfer your specimen. You got good cores, you put them on your trolley, and now you have to transfer it to the bottle which contains the formalin. You do not pick it up with tooth forceps or pick it up so hard that it crushes the tissue, because this crushed tissue will make it difficult for your pathologist to give you an answer. So pick it up gently with probably atraumatic forceps or mosquito, and then transfer it into the formalin sample and send it. This is one common practice that I have always seen happening in institutes, that you divide the specimen, send to two different pathologists. You send one to probably a trained or a reputed pathologist and one to your institute, and then you get two different answers and then you have a bias. Now, unfortunately, these tumors are heterogeneous, and what you biopsy, some specimens may have representative tissue, some may not. And when we're doing a blind division, you do not know which type of samples have gone to whom. Probably the experienced pathologist got the normal tissue, and the other pathologist got a good tissue, but he was not able to give an answer. So eventually you get a normal report from both ends and you tend to treat the patient that way. So avoid dividing specimens. You can always get your slides and blocks reviewed when necessary or when in doubt. And immediate weight bearing after a bone biopsy has to be avoided because however small the needle hole is, it is already a pathological bone, a weak bone, and abnormal loading of that bone can lead to a pathological fracture, which can lead to an hematoma, which can contaminate your neurovascular bundle or your soft tissues, again converting a simple limb salvage surgery into a probable amputation. So this is, maybe a pathologist who cannot see anything, he would say correlate clinically. And this is what happens when your MRI report is suggestive of a giant cell tumor. Your pathologist cannot give you a conclusive answer whether it is an osteosarcoma or not. You will tend to treat it like a giant cell tumor and then have complications because you did not really know what the actual histopathology or tissue diagnosis was. And from my side, the take-home message is plan well. Your imaging is necessary. Do not hurry. If you feel that you are not negotiating the hard bone and getting into the tumor, wait. You can control or you can sedate the patient further, or you can convert it into an anesthesia procedure. But get adequate tissue. Do not feel it has been 10 minutes and I'm still struggling with a small biopsy procedure. This procedure has to be done well. Once is the best chance that you get. Do not violate planes while during needle biopsies also, as well as during open biopsies. Achieve hemostasis and send the sample to an experienced pathologist to get the right report and then proceed with the further management. Thank you. So I think there is one question on the chat box which says that for taking core needle biopsy, should we apply tourniquet or not? So I don't think it is required because a core needle biopsy is a centimeter of an incision. Then you insert your needle and then you go directly into the lesion. You rarely get a lot of bleeding in a core biopsy unless it is an aneurysmal bone cyst or by chance while putting the needle your trocar hits a feeding vessel. All this bleeding can be controlled and doesn't require a tourniquet per se for doing a core needle biopsy. So the next question is that I learned that core needle, the core has to be transferred directly to the specimen bottle rather than the trolley, and then bottle is supposed to be transferred to the trolley and then, okay. So to, probably just clarify this, what happens is when you get your cores and you take them out into a container which is hyperenized saline, once your complete 6 to 7 cores are, you receive them, then you filter them out and then see which are the cores which is fat, which is just blood clot. If you transfer everything into the bottle initially, you might get a lot of tissue which is unnecessarily in the bottle, or you might not be able to see what is being transferred there because the blood which comes out with the core will get mixed in the bottle. So we usually take it out in one container and then transfer it into the bottle with formalin. And I think the next question is it okay to cross physis for intra-articular lesions, or is it intra for benign looking, avoid the physis? So again, yes, you should avoid the physis because you don't want to injure the physis and cause growth arrest or, abnormal growth. Looking at the image, you can plan where your needle has to be, inserted. Physis is a very thin line, so I don't think it should be a problem that you have to negotiate the physis, or you might accidentally injure the physis while doing a biopsy. In OGS cases, very vascular mass, what measures stop bleeding? Again, like when we do a core needle biopsy, a vascular mass, you should avoid your, vessels which are feeding to the tumor when you're doing the biopsy. And little bleeding that occurs during these procedures can be stopped by just pressing 5 minutes and causing and leading to hemostasis. So I hope this was clear and we can move ahead. At this point, I would like to invite Dr. Ashish Gulia, who would talk about this Nurture the Future program by the Sarcoma Education Foundation. I think sir is not online right now. So then what we'll do is we'll move on to the next session, and that is the case-based discussions moderated by Dr. Manish Pruthi, consultant orthopedic oncosurgeon at Tata Memorial Hospital. We would like sir to take over.
Yeah.
Yes, sir.
Hi, everyone. Yeah. After 2 excellent talks on biopsy, we'll proceed to the next session, which is case-based discussion. So I think most of the queries that we have, like whether to go through the physis, how to stop bleeding in a biopsy, or whether to use tourniquet, I think we can cover all that questions here. So for the first case presentation, I would like to invite Dr. Prashant Narhari, who will be showing a case for a biopsy of bone lesions. So over to you, Dr. Prashant, and welcome to Sarcoma Nurture the Future program.
Hi, good evening to everybody. Can you hear me?
Yeah, you are audible.
Right.
Yeah.
Okay. Right. Thanks a lot for having me here. I think the 2 talks before were very important, and I think I also echo what Vishnu and Michelle has mentioned, the importance of biopsy and how we as orthopedic oncology surgeon do see a lot of, wrongly placed biopsy in our practice. And when we get those type of cases, we always feel that, things would have been so much easier and better for the patient if the patient would have come without the biopsy in the first place. So let me just share my screen and we can go into the presentation on bone lesion. Okay, can you see my screen?
Yes, Dr. Prashant, yes.
Right, okay. So as we were mentioning, to me, I think biopsy is one of the most important thing. In fact, it's the beginning of how you start treating your patient, And if you got that wrong, you can be the fastest runner. So it's basically like this, you're running on the wrong direction. So, if you mess up your biopsy, you can be the fastest runner, but your outcome is not going to be good. So this is a patient. I would like to say sorry because, I've actually taken a patient with a pathological fracture, but I think this image probably gives the best input for our discussion for today. It's a 21-year-old lady who presented with right thigh pain and swelling for past 2 months duration. She bore with it. She was okay. She was walking around with the pain, and suddenly she had this severe onset of pain and inability to walk. And she comes to the emergency department with a pathological fracture of right distal femur. And as you can see from the X-ray, you can see that there is some abnormal bone formation there. And this is very suspicious of aggressive bone lesion. So this was the MRI which was done. So do we make this like a discussion, or
yes, Dr. Prashanto, I think we'll take some inputs before we tell them our thoughts in how we have planned a biopsy here.
Okay.
So I think that will give them a much more insight, in the sense that now they will have a much more clarity if the people participates more, and then we can correct them or we can guide them what was the best way out.
Sure.
Yeah.
So this is the MRI.
You can continue. You can continue the relevant questions. If required, I'll add.
Right. Okay. So this is the MRI of the femur which was done. Right. The coronal cut and this is the axial cut. Huh? So anybody would like to suggest how would you approach a biopsy for this distal femur lesion?
So we would like to have the answers in the chat box, and please be free. Like don't hesitate, because I think that is the thing that is going to give you the best possible understanding of doing a biopsy.
Right. So I've given you options.
Yeah.
So how many would say we go medial? How many would say we go lateral? And how many would say we go direct anterior? So okay, let me give you more. Right. Okay. So that's the medial.
So one of them has suggested lateral inferior segment.
Lateral
and the other person is also lateral.
Okay.
Yeah.
Any reason why you would go lateral rather than medial?
Ashwin is asking for full length MRI. Someone is asking for a soft tissue component.
Right. Okay.
Yeah.
All right. Very good.
And one of them wants to avoid the vascular, but a vascular bundle will be posterior here. It is not much medial here. So because if we have to do a medial biopsy, we'll be doing anteromedial, and you can see in the axial cut, vascular bundle is posteromedial.
Right.
So
I didn't even put posterior here because I think that goes without saying. I know you shouldn't go from posterior. I think the argument would be
someone has avoided for asking for lateral, avoiding medial, because the vascular bundle will be there. That is what I could understand.
Okay.
So I think Dr. Prashant, you can take up you can tell the relevant points. First thing, what biopsy you have chosen, and second thing is why you have chosen that based on the final surgical plan. Okay.
Right.
So and then maybe people will have much more clarity. Yeah.
Okay. So yeah, you could go from medial, you could go from lateral. I think direct anterior is a no-no. Okay, for distal femur, I think Dr. Vishnu has made it very clear. You could go medial, you could go lateral. However, I think Dr. Ashwin has mentioned about full-length MRI, right? So I purposely didn't show you the entire length. So I think before making a decision for biopsy in this type of cases, it's very important to look at the full-length MRI. And here it's obvious that this tumor actually extends, the signal actually extends all the way to the proximal femur. You could see some lesions around the femoral neck as well, right?
So Dr. Prashant, how does it change your biopsy site, whether if the patient is, the lesion is going up to the neck or not going up to the neck? Does it change your biopsy site?
Definitely, definitely. So if the lesion is only over the distal side, then we could go lateral or anteromedial. But in this case, our definitive treatment is probably going to be a total femur. So I would definitely go lateral approach rather than medial approach for this case.
Absolutely. So for everyone to understand, like for a biopsy of a lower end femur lesion, the preferred approach is anteromedial or a medial needle biopsy. Okay, you can do lateral if the soft tissue component is predominantly on lateral side. Otherwise, the preferred approach will be a medial or an anteromedial biopsy. But when the lesion involves the total bone, your surgical plan changes. Now you have to do a total bone resection, which is usually done from the lateral side. It is very difficult to put an implant from the medial side in total femur. So that is why it is like pertinent to have a full length MRI before planning your biopsy site. Great, Dr. Prashant, you can continue. Yeah.
Right. So I think that's exactly what we did. We went in from the lateral through the vastus lateralis and took a specimen from there. So now the question is, how high do you go? Do you go at the fracture site? Do you go slightly lower, slightly higher? So I suppose when there is a pathological fracture, I think it was mentioned by Michelle earlier or Vishnu, I can't remember. But you try to avoid the fracture hematoma and the necrotic area. You probably want to go a bit more higher. You could go through the fracture site and put your a curette into the more relevant area to take the biopsy.
So is it like Dr. Prashant, like is it like going like in this case on X-ray we were quite sure that we are dealing with an osteosarcoma because it's a new bone formation in the soft tissue. Right. But is it like doing a fracture biopsy from a fracture site can confuse the pathologist if there is some callus or something? Yeah.
So I suppose if it's a fresh fracture, shouldn't have much of an issue. But sometimes this patient comes in after about 2 weeks. Then the callus formation might confuse the pathologist. But I suppose with all the staining that we have, and if you send to someone who has been seeing osteosarcoma for some time, it's not so. How do you say it? The more seasoned pathologist will be able to tell the difference between a normal osteoid formation and a malignant osteoid formation.
Okay. So, but yes, sometimes still in a benign lesions with a pathological fracture, when they're presenting late, a new bone formation, a early callus can be confusing. So I think it is better to avoid a fracture site as for the reasons that you have already mentioned, as well as for because the callus is forming and which can be and immature bone can be very confusing for any.
I agree with you.
Yeah. So
I suppose any questions on this? Let's just have a look at this. Can callus be confused with osteogenic sarcoma?
How many cores? Question, how many cores? I think that's a very relevant question, Prashant. You can take that.
Right. So I think at least we need 3 cores. In my practice, I take 5 to 6 cores just to be on the safe side.
So what size of needle you use?
Okay, I try to use the biggest one, 12 or 14 gauge.
12 or 14 gauge. And when you say 5 to 6 cores, what is the usual length of your core? Like, because sometimes we don't get a centimeter long core. Okay, right, so what is the usual length of your core?
Yeah, so we try to get at least a centimeter, but sometimes it's not so easy to get that. But good 5 to 6 scores, I think that will be okay. So if you get very good length score, then I probably stop at 5. But if I don't, then I'll go for the 6th one.
Okay. And another question I want to ask, like, do you always collect your biopsy cores in a saline, or do you initially, or you want to collect in a dry gauze and then shift it to the formalin? So how do you do that? Yeah.
Right. So once the trocar comes out,
Yeah.
I will unload it onto a saline gauze.
Okay.
Right, and then carefully pick it up and put it into the formalin.
Yeah. So absolutely. So I think this is a very important point. Like you need not put all the time the course in the saline bowl, because it is better, because the course directly have been put into the formalin solution. So once you to put it in a dry gauze, then you can straight away put it into a formalin solution. But yes, if there is lot of hemorrhage, if there is lot of bleeding which is happening, then you have to collect in a heparin saline solution and then filter the course and then shift it to formalin solution. So any other media that you use for transfer, or you are happy with 10% formalin? Any change, anything?
No, we use 10% formalin.
Yeah. So for everyone, I think the standard practice is 10% neutral buffered formalin, and you should not be sending the samples in saline or a direct tissues like that. So it is straight away the 10% formalin. So
Yeah.
another small question, Prashant. So do you usually ask for a immunohistochemistry when you are sending a biopsy sample?
Right. So if I'm quite confident that this is going to come back as osteosarcoma,
okay,
I will send in for histopathology only.
Okay.
Right. But the place that I work in, they almost always proceed with immunohistochemistry.
Okay.
But if I'm having any doubts, if I'm doing a biopsy where I'm suspecting maybe this might come back as Ewing's or what you call a metastatic lesion, then I always ask for immunohistochemistry.
So more or less, like you tend to write a reflex ISC kind of a thing. Like if required, they can proceed with the immunohistochemistry.
Yes, I do that. Yes, I do that.
So any other person who has any other queries about a biopsy of a bone lesion?
So maybe just to add, we mentioned about putting the sample into formalin. Okay, unless you're doing a frozen session, then you don't put into formalin.
Agree. Yeah.
So that you send fresh.
Yeah. So one more question, Prashant. Like, do you culture your biopsy always? Because that is like some people initially it was a dictum like you culture all biopsies and biopsies all cultures.
Right.
So, but do you culture all your biopsies?
So I think we will go for that based on our clinical assessment, right? So all these patients do get an ESR, a CRP, alkaline phosphatase, LDH, calcium, and all those things done. So from those blood investigation and history, if there is any suspicion that this might come back as tuberculosis or something like that, then we do culture our biopsies. But if we see it's clear-cut tumor material, then we don't routinely culture every time.
Yeah. So for all the delegates to understand, like we actually discuss before sending a patient for biopsy with in a tumor board, like what is the tentative or what is the provisional diagnosis. If our diagnosis is clear-cut a malignancy, then we are not doing a culture. But any deviation from a standard clinical picture or standard radiological picture, or any suspicion of infection, and as Prashant has mentioned, like doing an ESR CRP, any suspicion, we tend to send an aerobic culture with the biopsy. Is that correct, Prashant? Anything?
Yeah. Yes. Agree. So
so someone has actually asked, like on MRI, which features suggest neurovascular bundle involvement? Can you take that, Prashant?
Okay. So I think to see the normal structure, it's probably easier to see in T1 images.
Yeah.
Right. So like this image, the one that you can see down here, right? It's probably easier to look at the neurovascular bundle in T1 images.
So I think like it is just a standard practice to go through all the axials, and we can easily make out where there is the neurovascular bundle in relation to the tumor, and we can easily guess whether the neurovascular bundle is involved, abutting, or free.
All right.
Yeah.
And I think to sum up, I think the learning point from this case is, always think of the definitive surgical plan when deciding where to biopsy from. So in this case, although the lesion is in distal femur, we would have considered medial or lateral. But when you look at the entire femur MRI, we know that medial approach is not the correct approach. Lateral is the way to go. And we get full length images before biopsy. And remember, biopsy is always the last step in your local staging.
And one small question, Prashant, which is there, I think, will the biopsy from soft tissue component suffice for a bone tumor?
Right. Okay. So I think there is a bit of a debate in this, right? Especially if you're talking about, I think there's no debate if you're talking about Ewing's or something like that. But when you talk about osteosarcoma, there is a bit of debate on this. Because for the pathologist to say this is osteosarcoma, they need to see the malignant bone formation, right?
Yeah.
So if you don't give them adequate bone sample, they might not be able to say that this is osteosarcoma. They might just say that this is a high-grade spindle cell lesion arising from the bone based on the radiological finding. So some people are adamant to get the sample from the bone. However, we know that even the soft tissue component of an osteosarcoma do have abnormal bone formation. So yeah, you can go either way. I personally, whenever I've given a chance, I try to take the soft tissue as well as the bone component.
Amit, you want to add on that? Is Amit around? Amit Janu?
Yeah, so basically we have to see whether which is the most representative area. So it should not include any necrosis or an area which is hypoenhancing or something like that. And if you are suspecting, suppose like correctly said it, whether it is Ewing's or cartilaginous, so we will include both of these areas in a single biopsy.
Yeah. So I think the important point here is like, because the soft tissue component can have a lot of necrosis. So in that case, as Prashant is also telling and as Amit, because in that case, we can target only, if you target only the soft tissue and in the necrotic, then you will get a negative biopsy. So in those cases, reading an MRI and targeting an appropriate site is very adequate. But neoplastic bone formation is equally representative, but yes, we should be targeting that area rather than only the soft tissue component, because that could be only necrosis. Yeah. I think if there are no further questions, we can proceed with the next talk. This will be on a biopsy of soft tissue lesion by Sandesh Thete. Sandesh, all over to you.
Is my screen visible, sir?
Go ahead, Sandesh. Go ahead.
Yes, Sandesh, is visible. Go ahead, please.
Thank you. Thank you. So I'll be presenting on biopsy of the soft tissue sarcoma. So I have selected this case. She was a 41 years old lady presented with complaints of a painless swelling on the inner aspect of her thigh, left thigh, since last 3 months. It was gradually progressing in size. Other than that, there was no significant history. This is the T1 coronal image I have selected, a full length section of the thigh. You can see there is a globe rounded lesion on the medial aspect of the thigh. So these are the T1 and T2 axial sections. I have not included the sagittal section because that was not very contributory. So you can see the mass is mainly arising from the adductor longus, the sartorius to the anterior, and adductor brevis to the posterior to the lesion. And neurovascular bundles are in the close proximity, just below the sartorius muscle.
Yeah.
So the points to this is the contrast image I have selected for further discussion. The points to consider in this case will be the size of the lesion, whether it can be biopsied without any image guidance, like CT guided biopsy. If you will need a CT guided biopsy, or you can palpate it with your hands, you can locate it, keep it in place, and put your biopsy needle in it. Or you will need a USG guided or CT guided biopsy. Consistency of the lesion, whether the lesion is cystic, whether it is whether the lesion is cystic or there are some necrotic areas. Because cystic lesions, you cannot do a biopsy with a true cut biopsy needle. Heterogeneity of the lesion, because some soft tissue sarcomas, they become so huge that there are different areas. Some are benign looking areas and some of them are malignant looking areas. So in that case, you will have to target the malignant looking areas, which you have to decide before you go ahead with the procedure, and that has to be discussed with your radiologist. Then while for the actual execution, you need to calculate the distance from the skin of the lesion, because on the true cut biopsy needle that we will be using, there will be markings. 1 centimeter of 0.5 centimeter markings are given, so you can know that okay, at this level I will have reached my lesion. So distance from skin is very important. Relationship to surrounding muscles, whether you have to go through the muscle, like in this case, it is arising from adductor longus and there is no muscle covering it. So in this case, you will have to go directly to the lesion. Otherwise, I would have gone through adductor brevis or some other muscle. Relationship to neurovascular structure. Here we can see the neurovascular structures are anterior to the swelling. So we know that we have to avoid that area. So we always keep that in mind. And we always keep in mind the final surgical approach and the site of incision that we'll be taking for excising this lesion. Manish sir, you can add if I have skipped anything.
No, I think you have covered all relevant points. So what we'll do is we'll take the delegate's opinion, like how do they want to biopsy this lesion before you tell us the best way out. Okay, and we'll take like whether they want to do without image guidance, with whether they need a ultrasound guidance, whether they need a CT guidance, and what kind of biopsy they would like to choose. So you can just go through the scan the images again on the screen, and then let us take their opinion first.
So this is the and I would prefer if any delegates want, they can unmute their audio and they can ask questions directly.
So someone has said shorted distance from skin core biopsy. Okay. So that will be enteromedial, I guess, in this case, if Dr. Ved Prakash, if you want to add.
Yes. I'm not able to see the chat, so I'll look at the chat.
Dr. Sandesh, I have a question. Why don't we just excise this lesion? Why don't we do an excision biopsy? It looks small. We can just excise it.
Excellent question, Vishnu.
Sir, it is deep to deep tissue, so I will not be very comfortable doing an excisional biopsy. If it would have been a subcutaneous lesion above the deep superficial to the deep fascia, I would have considered a excisional biopsy. But in this case, looking at its intramuscular location and all, I was not very comfortable taking
So
it
the
out.
question here is like, what are the indications of doing an excision biopsy in a suspected soft tissue lesion? Yeah. So we'll discuss that. Yeah, we'll discuss that again. I think Vishnu, for the timing, we'll focus on this case. And there's another case, another comment like on MRI, does it look like a schwannoma?
This case? No.
Yeah.
I don't think so. I think it came out to be synovial sarcoma. I'm not.
Yeah.
So
basically, I think the question here is quite clear. Like
Manish, maybe Amit can comment on how schwannoma looks on MR.
Yeah. Amit, you are there. Amit, please. Is Amit
Hello.
there?
So basically, So schwannoma will have a very peculiar characteristics. One is that it is very T2 bright, and that we can see the schwannomas are, and it will show progressive slow filling enhancement. So something which is very classical. In those which are not very classical or indeterminate, then we will move ahead with the biopsy.
So I think more than that, like what we need to understand is whether we are dealing with a benign tumor or malignant tumor, or whether actually this patient needs a biopsy or a diagnosis for us to proceed for the treatment. So the answer is very simple, like any tumor which is deep to deep fascia, which is more than 5 centimeters, which is growing. Okay, we are talking about soft tissue tumors, whether or not it is painful, needs a biopsy. Okay, so before going ahead with the treatment, so the answer is any tumor, any swelling which is deep to deep fascia, which is more than 5 centimeters, which is growing, whether or not it is painful, you have to suspect as a soft tissue sarcoma. Whether it turns out to be a schwannoma or a neurofibroma, that is a different thing. But you have to suspect a soft tissue sarcoma and do an appropriate investigations and plan for a biopsy. Okay, and to answer Vishnu's question, I think Sandesh can take that. Like, when do you do a excision biopsy? Yeah.
So, like Manish sir said, whatever is not, whichever is superficial to the deep fascia, less than 5 centimeters in size, preferably less than 3 centimeters in size, can be taken out with adequate margins as a excisional biopsy. But God forbid if it turns out to be dermatofibrosarcoma, then your margins may be inadequate. So always try to go for a biopsy if it is a very small lesion and you are very confident and very experienced, I must add, then only do it without a biopsy. I usually do a biopsy unless and until my radiologist says ki it is very benign lesion or it is a fibromatosis. Sorry, not fibromatosis, it is a benign lesion and you don't need to biopsy that. Then only we will avoid biopsies. Otherwise, for all our soft tissue lesions, we'll go with a biopsy.
So excision biopsy, as Sandesh has rightly pointed, is reserved for a small superficial lesions, usually less than 3 centimeters. But that also has to go through an experienced musculoskeletal radiologist, like we have Amit here. We discuss the imaging with there. We decide and we see whether the margins we can get easily, whether patient requires a plastic surgery procedure because of a skin involvement or not. So per se, for all practical purposes, avoid excision biopsies unless you are sitting in a tertiary referral care center where you have a good pathologist, good radiologist to help you in planning the treatment. Otherwise, it is always good to biopsy first, even for a small lesion, so that you can plan your adjuvant treatments along with it. Like a small lesion, you will tend to give an adjuvant brachytherapy rather than give an external beam radiation. So it is good to have a biopsy beforehand. So I think we'll go ahead with this case. So it's a deep lesion in the anteromedial compartment of the thigh, and someone has suggested an ultrasound guided biopsy. So Sandesh, you can take on, like, what is the best way you have done the biopsy in this case?
Yeah. So for this case, I will definitely go through an anteromedial approach. I will take at least, like we discussed, 5 or 6 cores. So this is a 2-dimensional image. So I have represented only 4 cores. But if you imagine it 3-dimensionally, you can definitely get 5 or 6 cores. So if you can palpate the lesion, hold it into a place, and you are very, you have done this procedure before, you can, in this lesion, you can do it without a USG or CT guidance. I did it without USG or CT guidance. But if you are not used to doing soft tissue biopsies, especially when they are this close to the vascular lesions, you should always go for a USG or CT guided biopsy.
Can you point the neurovascular bundle here, please?
Yes.
So see this. So the neurovascular bundle is very close, and you can see a very thick subcutaneous fat here in this patient. So I think in this case, although with an experience, you can do a biopsy without guidance, but I think Amit will also agree with me here. Like, it is better to do a biopsy under guidance. And USG guidance is very easy, and we can definitely avoid a neurovascular bundle here, and we can be much more sure about our course, because the soft tissue tumors can be heterogeneous. We might enter a necrotic area. So Amit, you can add in that, like, what will be the best way to biopsy. I'll prefer a USG guidance here.
Yeah, Manish, I think USG is the best placed one. One, we can see what are the neurovascular bundles which are near about. Second thing, whether we know that whether there is any cystic areas, any hemorrhagic areas, or any necrosis, or any other structure which might compromise our biopsy. So basically, under that guidance, we can get to know whether which is the best suited area within the lesion itself, also apart from creating complications.
Yeah. So Michelle, you want to add on that? Sorry, Michelle or
so Michelle has asked a question where we did change the direction. So I was not able to get these arrows aligned up properly. So the direction has to be changed at the level of the capsule and entry point.
Yes.
So what I wanted to stress is that for all your cores, the entry should be from the same place.
Yeah. So can you mark that, Sandesh, because this is become a little confusing for everyone. Yeah. So from the skin up to the tumor capsule, you go in the same line.
You have to go in single line, and here you will go in different areas.
Yeah.
So right now we are having the coaxial needle. So the entry will be similar. The cannula will be placed within the tumor, and then you can change the direction of the cannula. And the shoot that will be taken, it will be in the different course wherever you will direct the cannula.
Amit, can you explain this a little further for everyone? Like, what is the coaxial needle and how do you do that? Yeah.
So basically, we have a coaxial system where there is an outer cannula and then there is a inner needle. So with the stilette, we will introduce the cannula and the needle together. Once we are within the tumor, then we will introduce our needle, and then we will direct the needle into different directions, upwards at the same level, and the downwards, medial and lateral. So we can get a good amount of core, and we can advance the depth also. But within the tumor itself, we are not piercing the tumor from either sides. So actually, we can get around 8 to 9 cores in that particular.
And your outer cannula remains for the full procedure. Like our biopsy needle always goes through the outer cannula. It remains till the time you have completed the full procedure.
Yes, completely.
So that there is no contamination of there is not much contamination in the skin, subcutaneous tissue, or just around the tumor. Yeah, that is what you mean.
Yes.
So it is very good to have a coaxial needle system in soft tissue biopsies, because then you avoid multiple entry points from the skin and subcutaneous tissue, and then you can just have a multiple course through the different part of tumor. And Michelle, Sandesh, if I can ask you, why to take a course from multiple directions? Why it is not fine in taking from only from one area?
So like I said, sir, there are some these soft tissue tumors are very tricky. There are heterogeneous areas. So you might not get a representative sample. Most of the time it happens that you get a report saying that there is no malignancy seen, whether even if you have hit the tumor quite well. So it is better to take from different directions and from different depths of the lesion, so that your chances of getting a positive tissue diagnosis are increased.
Yeah. So basically the sarcomas are heterogeneous, and that is why we want to target different areas. So another small question that I have is, like this the same question I asked to Prashant is, do you always send immunohistochemistry when you're doing a soft tissue tumor biopsies?
So for soft tissue sarcomas, yes, sir, we counsel the patient beforehand that the preliminary histopathology may not be adequate, and you might have to do a immunohistochemistry. We do not ask them to pay upfront, because sometimes we get a confident diagnosis on histopath only. But most of the cases of soft tissue sarcoma, yes, we are doing ISTs for that.
So as a practice, like we are sending
Manish,
all
time,
soft tissue.
time.
Yeah, sorry, sir, but just last comment. Yeah, as a practice, we send all soft tissue sarcomas for a reflex ISC. Reflex means whenever they need, they can go ahead with an IFC without actually we charge them initially only. So I think with this we'll conclude this part of the talk. And may I invite Dr. Gulia first to give his inputs on the Sarcoma Education Foundation and Nurture the Future program before we proceed with the next talk on cystic bone lesion. Over to you, sir.
Thank you so much, Manish. And it's very encouraging to see everybody joining. And I just wanted to update everyone that Sarcoma Education Foundation is a niche initiative which has been created to promote education among patients and among doctors, whether they are students or young colleagues, about sarcomas, whether bone or soft tissues. And this is non-profit organizations which will keep doing the education activities themselves, and in association with various societies and associations across the country. Particularly today, I want to thank Dr. Akshay Tiwari and Dr. Michelle Parikh for putting all the effort to organize this. And congratulations to all the speakers and Manish for putting up a great show. I will also encourage delegates to spread this information to your colleagues in the groups, that every second Saturday, irrespective of holiday or working days or any other parallel conferences, we will be doing this 1.5 to 2 hours session to spread the education about basics of musculoskeletal oncologies. So spread the word around and let everyone be benefited. Thanks, Manish. Thank you so much.
Thank you very much, sir, for telling us about the Sarcoma Education Foundation. And I think maybe in next few months we'll get much more participation, and like it is a very useful program. And we are basically discussing the just basics of orthopedic oncology, which are very relevant in anyone's practice or even during the initial post-graduation. So I think with that, we'll proceed to the next talk, which is very important, the biopsy in cystic bone lesions, because this is a procedure which is very tricky, because you need to get a tissue from a cystic area, and there are certain special techniques in which we can get some tissue for a diagnosis. It's a challenge for a surgeon, it's a challenge for the pathologist. And I guess we have a wonderful person to speak on, Ashwin. So Ashwin is an alumni of TMH, and Ashwin, you can give your insights on how do you biopsy a cystic bone lesion.
Thank you, sir, for giving me this opportunity. Dr. Pratik, you can start that screen sharing. So before that starts, I would like to say one thing, that before you decide that this is a cystic lesion, you must be sure that this is a cystic lesion, because many a times there may be a huge cystic lesion and there will be some soft tissue component lying somewhere, and you may miss biopsying that, and you may get a result like it's an ABC or something, and later it may turn out to be a telangiectatic OGS or something. So before you label it as a cystic lesion, please be sure. If you need a contrast imaging, get the contrast imaging done. I mean, and then you just label that it's a cystic lesion, and then we will go on how we should biopsy a cystic lesion. Like this was a 16-year-old girl uh, with right side hip pain for around 10 months, and there was a lytic lesion into the neck and the head of the right side femur. And on MRI, this is a next slide, please. There was a clear cystic lesion with a fluid levels on both coronal and on axial. Next slide. Next slide. So we decided that, okay, this is a cystic lesion. Now, especially, it is very difficult to biopsy such lesion when it is in the head or neck. So I will try and demonstrate that also, that how easily we can try and biopsy such lesion. Next, like we targeted, I mean, under C-arm, especially in this case, I started with an ST pin, because it is very easy to change the direction of an ST pin, I mean Steinman pin, rather than our Jamshedi needle, because it may bend when you try and bend it once it is inside the bone. So under C-arm guidance, because this lesion was more in the posterior aspect of the neck, we saw on both the planes, AP and lateral, and then we targeted the lesion. Next. So and once you are into the lesion, you have to break all the septas and scrap the wall of that lesion. I mean, whichever is possible. So then we made sure that, okay, we are in the lesion. On the coronal image, it was right from above to down, and in the axial images, we were like, it is in the posterior. So we targeted that lesion. Next. Then we break all the septas. Okay, this video is not working.
It's working. It's working.
Yeah, it's working. Okay. So this is how you should. So the same thing we are supposed to do with Jamshedi needle, but in such cases it may bend. So first you can break all the septa, and then you in the same track you can put in a J needle, and then try and scrape the wall of the lesion and take as much tissue as possible. While doing that, you can give a negative pressure with 10 cc or 20 cc needle and try and take an tissue. Next. So, and you must make sure that you have broken all the septas, and you have scraped the all part of the lesion. Next. So this is how you biopsy in a cystic lesion. So many a times you may not get the diagnosis like just an hemorrhage or these or that, but that can be sufficient when your clinical suspicion was an ABC or UBC. So it's, negative biopsy in a cystic lesion be the clue that, okay, you are dealing with a benign bone lesion. But first you need to be sure that, yeah, it was the cystic lesion. Okay.
Yeah. So
thank you, sir. That's from my side. Yeah.
So great presentation, Ashwin, in the sense that you have actually explained how do you scrape the wall, and it is very important to scrape the wall and aspirate that tissue so that we get the membrane of that cystic lesion which will be examined by histopathologists. So just to ask, like in this case specifically, why did you choose an approach through the trochanter rather than going directly into the lesion?
So, sir, I mean, I found, you mean directly horizontal?
Yeah, you could have gone directly anterior and under a CT guidance. Was that a possibility here, or what was
I
your
mean,
thoughts? Like,
direct
yeah,
anterior, you mean? Okay.
yeah,
So, I mean, in worst case scenario, this can
yeah.
turn out to be some malignant lesion.
Okay,
For that, you are going to take a direct lateral approach for proximal femur resection. And if we go anterior, we may contaminate rectus or maybe vessels or something, which we
yeah,
always try and avoid in biopsy, that you breach as less compartment as possible. Like, this is not the shortest route, I mean, to
okay,
reach the lesion, but this
yes,
essentially matlab keeps that rule that you breach the least compartment. Like, we have just breached a skin and a bone, which anyways, if turns out to be malignant, we will have to resect. But we
absolutely. So
can't
this is,
resect
yeah.
rectus.
So I totally agree with the point. This is what we should, like, all the delegates should learn. Like, we should always have a final surgical plan in our mind before going ahead with the biopsy. So suppose this is an aneurysmal bone cyst, it comes out, our plan will be to do a sclerotherapy. So that can be done from this biopsy approach. And if it turns in a worst case scenario, it can be a telangiectatic osteosarcoma. So in that case, because the lesion is anyway involving the head and neck, the patient will require a proximal femur excision, which is done through a lateral approach. Okay, so doing a biopsy and going through the trochanter is fair enough, because still you are contaminating the least possible area. If you go anteriorly, you will contaminate the rectus, you might contaminate the neurovascular bundle plane. So that will be much more damaging. So this is what we should understand. Like, we have to have a very clear understanding of the tumor and very clear understanding of the final surgical plan. So James has asked, like, can we use CT guidance biopsy to obtain cystic lesion for this case? Use Steinman pin to break the septa. Will the Steinman pin destroy the sample and give inaccurate sample biopsy? Ashwin, you can take that. Ashwin, are you there?
Oh, sorry, sir, it was not on. So
Yeah.
in this particular case, CT guidance will not, I mean, CM guidance will be enough to me.
Okay.
If you are not comfortable, then definitely you can take a CT guidance, but I think CM guidance is sufficient for this. Yes, especially when we are talking that if we break the septa with ST pin, it may take away some sample. Yes, you are right. Actually, to be very honest, I took in this video when I was putting in a sclero in already biopsied ABC, but I just wanted to demonstrate. So I have taken this video. You can make a track with ST pin. I mean, just to widen that proximal part of your track, and then you put in a needle and then you break the septa. Yes, you are absolutely right.
Yeah. So one point which Ashwin has not highlighted and which is very important and has been discussed earlier, like in cystic bone lesions, because more or less you are going to get blood, it is good to have the syringe heparinized. It is good to have a bowl filled of a heparinized saline, so that the clotting does not happen and you can actually pick and choose the tissue from in between. Okay, and there's a small one more question, like, do you send the fluid from the cyst for analysis? Prashant has asked. Is that even helpful? The fluid. Yeah.
Till now,
So
we actually don't, but yeah, there is a thing
so
like
we don't do that. I think we can take
centrifuge
Prashant's comment. Prashant, do you send regularly the fluid
we
from the
don't
cyst?
do, but yeah, it can be done.
Yeah.
No, I
No,
don't.
sir,
I don't. It's just that, once you break the cortex and once you're in the cyst, if you see that clear kind of fluid, then you're very sure that this is unicameral bone cyst.
Yeah.
But yeah, I don't think that fluid analysis is even helpful. What is helpful is the histopathology.
Yeah, the color of the fluid can guide you because whether you are dealing with a UBC or SBC, whether it is straw colored or it's hemorrhagic. But otherwise, sending the fluid will not help you. So I think with this, we'll proceed to the next talk, which has been partly covered, but Harsha can enlighten us on biopsy of a pathological fracture, because I think that is a very challenging situation, and more or less we lands up in a trouble when we are doing a biopsy of a pathological fracture because of a lot of confusion happening due to callus formation. Harsha, all over.
Good evening, sir. Can you hear me, sir? Can you see me?
Yeah, Harsha, you are audible. Your slides are visible. You can go ahead.
Yes, sir. This is a 16-year-old female, pain in the left thigh since last 6 months, and she had a sudden onset of increased pain and swelling while climbing steps for 1 week, and there's no history of any fever. And these are the X-rays which are clearly, we can see there is a fracture, or it can be it is a pathological fracture with soft tissue component, and we can see a little bit ossification in the soft tissue. And because I want to highlight 2 points here, because as we are in biopsy session, we should not forget our basics. Whenever the patient comes with a pathological fracture, it is important to stabilize the fracture immediately with a external POP splint, and there is no hurry like in a general orthopedics to fix the fracture. It is pathological fracture is never an emergency, and don't hurry to surgical procedure by doing interlocking nailing or something plating or opening it inadvertently, because that will breach the oncological principles. And this is the MRI which shows the sagittal T1 section, the soft tissue extent, the marrow extent, and also the distance from various physis joint and everything. And this is the axial sections of the MRI, which shows huge soft tissue component involving almost complete anterior compartment. But the neurovascular bundle is appear to be like not contaminated and away with maintained fat planes. And this is the contrast MRI. So while proceeding for biopsy with a pathological fracture, so the first decision would be like whether can we salvage the limb or not. Because if you are going, there is a gross contamination of soft tissue on neurovascular bundle when we are going for amputation, then that doesn't matter whether from which area we are biopsying and from which area, from which approach we are biopsying. And if at all we are like we are opting for limb salvage, then we have to decide like from what is the extent of the disease and what is the contamination the fracture has caused. So if you see this particular case in the MR, so it is far away from the joint and it is far away from the fascial line. So if the malignancy responds well to the neoadjuvant chemotherapy, then we can offer him a limb salvage. Like in this case, we can proceed for an intercalary resection. So if you are planning for an intercalary resection in this type of cases, it is better to approach on the lateral aspect from the soft tissue. And if you are planning for any, like if the joint or distal femur can't be salvaged, then we are planning for mega process. Then we can plan for a medial or lateral approach according to the surgeon's comfort. And for the definitive planning, after we have to keep it in mind, the pathological fracture after getting a biopsy report. If it turns out to be Ewing sarcoma, then pathological fracture is an absolute indication for radiotherapy. So that should be kept in mind. And if it is osteosarcoma, then we can there is no need of any radiotherapy. And one more thing, like in this type of fractures, when there is a contamination, if the nerve is preserved, rotation plasty is also an option in this type of cases, sir. So I approach this lesion from the lateral aspect, assuming that it will respond well and it is osteosarcoma from the X-ray, because the joint, it is far away from the joint, assuming that intercalary resection may be possible in future. That's it.
So Harsha, like I agree the lateral, but in the length wise, the lesion is I think almost 8 to 10 centimeters.
Yes, sir.
So where can you point in this image where exactly you want to put the needle, in the distal part, in the middle part, or in the proximal part, or is it okay in this case to put anywhere?
I think it is okay to keep anywhere because we can see a lot of soft tissue component, which is.
So can you put the axials? I want Amit to comment on that, because see, the problem here is the mainly is that the fracture hematoma versus the soft tissue component of the tumor. So Amit, how confident you are in telling us like whether it's a fracture hematoma or it's a solid component in the tumor after seeing the imaging? Is Amit around? Okay, Harsha, can you take that?
Yes,
like
sir. If we see the contrast MRI,
yeah.
So we can see that there is some bit on the lateral aspect. We can see on the lateral side, there is bit contrast uptake in this area, which we can target this area easily with an like a gun biopsy, and we can take the soft tissue.
Yeah. So just go back to the previous axials where you are showing. So as everyone can see, there's lot of solid areas in this tumor, and with there's some necrotic area in the middle part. So in this case, even in the axial section, going in the peripheral part of the tumor, I think you will get the tumor tissue. If you go very deep into the tumor, your sample will be contaminated by the hematoma. Yes. Otherwise, you can get to. That is why I agree with Harsha. In this case, you can go anywhere. But yes, if there is lot of hematoma around the fracture site, then it is best to avoid the fracture site and go a centimeter or two up or below, depending upon your like tumor extent in the MRI.
Yes.
So any queries? I think we have discussed already the biopsy in a pathological fracture during Prashant's case. So if there are no other queries, then I think we'll proceed with the next talk, which is biopsy in a spinal lesions by Dr. Agnivesh. So are you there? Michelle? Is Dr. Agnivesh, yeah, Dr. Agnivesh Tikku there?
See, it just message I sent him the link to join.
Okay.
Just confirm, sir.
Just confirm. Otherwise, in the meantime, we can take questions. We have wonderful faculty here: Dr. Prashant, Sandesh, Ashwin, Harsha, Vishnu, and Michelle himself. So, if there are any other queries, we'll take. Otherwise, we can go to the quiz and conclusions. Oh, Michelle, if it's difficult, then I think you can just highlight few points in a biopsy of a spinal lesions, and we can proceed with the quiz.
May I
Yeah,
highlight few points?
Ashwin, you can take that. A biopsy in spinal lesions. You can just tell few, because more or less the steps remains the same. But yes, you
Sir,
can highlight on.
He's logging in again, sir. He just logged out.
Okay.
He thought
Fine, perfect.
If he's coming, then perfect.
He's coming, sir. In 2 minutes, he's coming. Sir, one thing I just wanted to discuss. I was probably writing in the chat box. Now I'll say that there is a certain sort of a feeling that if you have got a CT guided biopsy, you can ignore the biopsy scar.
Yeah.
To what level is it true? Because a lot of regular general orthopedic surgeons who even share imaging with their orthopedic oncology friends and are advised biopsy, they would send it to their radiologist for a guided biopsy to save time. They don't have time in their busy OPD. Maybe the patient cannot reach the orthopedic oncologist for the biopsy. And in Ashwin's previous case, I have seen this happening, that the radiologist would do a posterior approach because that is the shortest route, and he would feel that why to negotiate so much of normal bone when I can directly hit the lesion from posterior side. And now if this comes out to be a telangiectatic osteosarcoma and you have to do a lateral approach for resection, how would you want to manage the scar? Would you be comfortable leaving it alone, or it would be worrisome?
So I think your question is like in a needle biopsies, especially a small core needles, like which is usually used in a CT guided, can we avoid a biopsy scar? So before we tell the practice in what we do in India, I think I'll take Prashant's comment in this. Like, what is the practice in Malaysia for CT guided biopsy when they're using a small core needles? Can you avoid a biopsy scars?
Yeah. Dr. Agnivesh has joined, so after this we can have.
Yeah, after this we can take that.
Sure.
Yeah,
sure. So I think very important for you to talk to your radiologist how you want them to put the biopsy needle in. That's the first thing, right? And my radiologist that I work with currently, if he's doing a biopsy, he will put a Daphlon stitch, a skin stitch, so that biopsy scar will be prominent even after the neoadjuvant chemotherapy, right? Because radiologists, I'm not sure what is the practice in India, but I think they sometimes have the tendency of just putting into the needle straight away, and when they come out, the biopsy scar actually disappears once the patient goes through neoadjuvant chemotherapy. So I make it a point that please make the scar obvious so that we know exactly where it was to remove it. And back to your question earlier, Michelle, I think we have seen cases whereby when the biopsy is done elsewhere, we're not sure where the biopsy was done from, and we ignore the biopsy tract. I've personally seen local recurrences in the biopsy tract later in life.
So as a practice, you excise all biopsy scars in malignant.
Yes, sir.
Yes, definitely.
And Vishnu or Ashwin, you can take on what is the practice in India? Like, is any difference, or is it the same? Someone has to unmute themselves before speaking. Yes, Ashwin.
Yeah, so for CT guided biopsy, to be very honest, sir, I mean, in private practice, when you are in TMH or tertiary care center, it's fine. But I mean, I'm very bit reluctant to rely on radiologists. I mean, sorry, it's not that, but I mean, they routinely many a times. I mean, in the private practice, they don't do. So many a time, I just go in the CT suite and do the biopsy.
Oh,
So
no, the
because
question here, Ashwin, is do you always remove the biopsy tracts even in a CT
yes,
guided
yes,
biopsy?
yes. So I mean, there was some debate, and there were some articles which were like, it's okay, the local recurrence are same, but all
So
these
you
were like,
always.
yeah, we always resect the biopsies.
Yeah, so
No doubt.
that is what we wanted to know. So always resect the biopsy
Okay.
scars, even if it's a small core needle biopsies, okay, because the contamination risk is always there, and everyone the data also says there are some tumor recurrences in the biopsy tracts. So with this, I think we'll proceed to the next talk. Dr. Agnivesh, all over to you for biopsy of spinal lesions. Michelle, is he around?
Yes, sir, he is logged in, sir.
But I'm just
call him.
So, Michelle, do
Yeah.
you have his presentation by any chance? Otherwise, you can just share that.
No, I don't have it.
So no worries. I think, Michelle, then we can just have a discussion on needle biopsies in spinal lesions.
Yeah, because we are already out of
Yeah,
time.
we were already late. Yeah. So I think, Ashwin, you wanted to say on spinal lesions?
Yes, so just I wanted to say one thing, that first you need to be sure that whether you really need a biopsy of that spinal lesion or not, because I think
Okay.
it's many a times most of the spinal lesion will be an elderly patient, where anyways a simple mat myeloma workup, and if you find out the primary, you don't have to biopsy the lesion, because
Okay.
anyway it is
Yeah, point
obviously
well taken. Yeah. So sometimes you might not need to, and you can find a much more accessible site of doing a biopsy by
yes,
doing
sir,
further
exactly.
investigations. Okay, that is one point. Any other thing, Ashwin?
And yeah, obviously it has to be done under CT guided, and yeah, I mean, this was the point that I wanted
So basically,
to
the
point out,
spinal
that
lesions we
first
are
be
doing
sure.
always under image guidance, and the preferred imaging is CT guidance, and we do a transpedicular biopsies. Okay, yeah, and because in CT guidance we can actually see the track of the needle, we can avoid the spinal cord as well as in the soft tissues. So we can actually see our track. And someone has asked, Ashwin, like, how much radiation exposure in a CT guided biopsy? So is it very important, because as you have said, you are going to the CT room and doing the biopsies yourself. So what is the risk of radiation exposure to a surgeon or an intervention radiologist when you're doing a CT guided biopsy? How much radiation do you get?
So basically, it is how much any person would get who is on the other side of that room. I mean, we just put in a needle, then we
Yeah.
don't remain inside when that CT cuts are taken, but we
Yeah.
just let it be there. We come out of it, then the CT images are taken, and then we see on the screen, and then we go in again, and then we change the direction. So it
Okay.
is as good as any one radiologist who is routinely doing CT scan at their center will get. I don't think that it is lot high or
So,
anything. I mean, at
yeah.
least
So I
for
think Dr. Akshay will be having a huge experience in doing a CT guided biopsy, because at Rajiv Gandhi, we as the surgeons used to go there. So is Dr. Akshay around? Can you highlight on the procedure of CT guided biopsies?
Yeah, Manish. So as Ashwani said, I think uh, usually it's only rarely required that you stay inside. Whenever CT is happening, you remain outside, looking from outside of the CT room. And I think that is not a concern at all, even for the intervention radiologist for that matter. So
yeah, and we usually put a guide wire, like, or a K wire in the track and see the direction, and then we can do the biopsy with the J needle, because when you know the track, then you can do even without a intra during the procedure CT scan, because
yeah, so you need two coordinates. One is the track and the other is the depth.
Yeah.
Once you have decided that the angle that you have taken is right, then all you need is because you have measured already, you just punch it a little bit in and then take your tissue.
Yeah, like a coaxial system.
Correct. Yeah.
Yeah. So I think with this, we'll conclude the session on biopsies. And if there are any further questions, you can put it on the chat box and I will request the faculty to answer. And over to Michelle for quiz and for conclusions.
Thank you, sir. I think we'll go on to the quiz, and Dr. Pratik is going to be running the quiz. This is on the Kahoot app, which was there in the brochure. Hope you all have downloaded it. So just to begin, we are going to have a demo quiz kind of a thing where, you will be able to get used to how this is. Not very complicated, but yes, you need to be, sort of up to date so that you don't miss on the timing and you can win this quiz.
Yeah. So thank you, Michelle. A fantastic talk and a panel discussion of a different sort, highlighting the various points to be covered in the biopsy. And now we are moving on to the last section of this webinar, which is on biopsy. So we have a quiz, which is basically an attempt to encapsulate whatever we have learned today and kind of give a revision to all the delegates. So for this, the panelists and the speakers can take a back seat and the delegates can try and participate and see how much they have learned and kind of revise. So for this, as we know, we need to download the Kahoot app. And once you download the Kahoot app, there is this option for joining a quiz. And you can see this game pin, which is being shown, 1762767. First, we'll obviously show the demo quiz so that one gets a hang of how to play this. And once that is done, we'll go to the main quiz. So a request to the delegates to join the Kahoot app and to join this quiz. And it will be a fun segment. And we'll see how much of what was taught is been retained. So, Michelle, can you see the screen and can you hear the background music?
Yes. I can see that we have 9 players who have joined in.
Okay. So this is just a demo quiz. So not to worry. Just download the app, open it, and once you see, you have to just enter this game pin in that. This first game pin is for the demo quiz. Okay, so we'll just wait if we cross probably 50. Any other players to join for the demo quiz? Or we'll just play the demo quiz now then.
Yes.
Okay, I'll just start the demo quiz. Okay, so this is a demo just to show how this works. So get ready for this. So the first demo quiz question is, who is the Prime Minister of India? Is it option red, Amit Shah? Is it option blue, Draupadi Murmu? Is it option yellow, Narendra Modi? Or is it option green, Rajnath Singh? So Amit Shah, Draupadi Murmu, Narendra Modi, Rajnath Singh. So we have got 10 participants who have answered. Last 9 seconds to go. 3, 2, 1. And the correct answer, as we know, is Narendra Modi. Someone has answered Amit Shah. So that is unfortunately not the correct answer. So that was the first question. And that is the leaderboard for the demo quiz. Remember, there is no prizes for the demo quiz. This is just to show how the game works. So going on to the second demo quiz. Which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Or is it green, Bangalore? Which of the following 4 cities is the capital of India? Red, Mumbai, blue, Kolkata, yellow, New Delhi, green, Bangalore. this everyone has got correct. It is New Delhi. So I think that kind of ends the practice quiz. So I'm assuming you have now got a hang of this. Just showing you the leaderboard of the demo quiz. Obviously, this doesn't have any prizes. So we'll go on to the main quiz now. Starting with the main quiz. Is the screen visible?
Yes, yes.
So now guys, the main quiz game pin which is being shown, which is being shared. So download the Kahoot app, open it and enter this pin 5761420. We'll wait for a couple of minutes for the members and the players to join in. So this is the main quiz that we have. So there were around 50 participants. So at least we are expecting half of them to join the quiz. So come on guys. 5761420. We have about 10 participants now. Brilliant, 13. This was the number in the demo quiz. I think rest of them are all faculty and speakers. Wait for a couple of more minutes in case anyone else wants to join in. You have to just download the Kahoot app and enter this game pin 5761420. Okay, we have waited for some time now, and that might be the number of participants. So, Michelle, with your permission, I can start.
Yes, yes, we'll start.
Okay. So, guys, remember this is the main quiz, the biopsy quiz. So, get ready. In this, you guys have to be fast, and you guys have to be accurate. You have to remember you have to be accurate and fast. So starting with the quiz, the first question, what is the preferred mode of biopsy in bone lesions? Is it red, excisional biopsy? Is it blue, FNAC? Is it yellow, J needle biopsy? Or is it green, incisional biopsy? And fantastic, everyone has got this answer correct. That is yellow, J needle biopsy. So I think there is no need of any explanation on this question, as was been discussed throughout the talk. J needle biopsy is the preferred mode of biopsy in bone lesions. Okay, so moving on to the second question of this quiz. There is an image which is shown proximal tibial lesion. What will be your approach for biopsy for this? Will it be red, anteromedial? Will it be blue, anterolateral? Will it be yellow, posterior? Or will it be green, medial? Anteromedial, anterolateral, posterior, or medial? And the correct answer is anteromedial, as Dr. Vishnu has covered in his talk initially. Through the subcutaneous border is where we go for these tibial biopsies. So, Mr. if you can just...
Yes. So if you see the image here, you can see a lytic lesion in the metaphyseal region of that proximal tibia. You do not know whether it is malignant or benign. You do not know whether your final surgery is going to be a curettage or excision. So hence, when you go with an anteromedial approach, you are very safe because that is your approach for an excision as well as for a curettage will require probably cementing and plating. So anteromedial approach is the preferred approach for a proximal tibial lesion. irrespective of what you are suspecting it to be.
Great. So I think that was also covered extensively in the talks, and considering the amount of right answers we have got, I think that has been correctly imbibed by the students. This is the leaderboard at the end of the two questions. RR is leading. Come on, others, join and buck up. Okay, let's go on to the third question of this quiz. When will you biopsy this lesion? There is a tibial lesion which is shown. Will you biopsy it red immediately? Will you biopsy blue after an MRI? Will you biopsy after a CT scan? Or will you biopsy after a PET scan? Immediately, after MRI, after CT, or after PET? Last 10 seconds to go. When will you biopsy this lesion? And time's up. The correct answer, as we know, is you have to get an MRI done.
So again, like we've discussed throughout the session, that without a full-length MRI, we should not go for a biopsy for reasons that have been explained previously. In this, the fourth option was after a PET scan, which was again brought up by one of the delegates, that should we complete all the staging before we do a biopsy? With a debatable, answer, I would say that let the staging be when it is proven to be XYZ type of a tumor, because in this case, to me, it looks like a benign lesion, most likely a fibrous dysplasia. This will not require a PET scan at all. So why to do an unnecessary investigation? X-ray, MRI, and then a biopsy. That is the cycle that we follow, and that is what works best.
Excellent. So let's move on to the next question. Biopsy is done for red to establish a tissue diagnosis, blue to plan chemotherapy, yellow medical legal safety, or green all of the above. Is it for establishing a tissue diagnosis and to plan a chemotherapy? Is it done for medical legal safety, or is it all of the above? Last 6 seconds to go. 3, 2, 1. And the correct answer is all of the above. So majority, in fact, almost all have answered this correctly. So I think that's pretty evident as to why we need to do a biopsy. But Michelle, if you can just add a 2 cents about it.
So here again, to establish a tissue biopsy, that is the main purpose of doing a biopsy. To plan chemotherapy, because chemotherapy differs from sarcoma to sarcoma. So once you have a final histopath of osteosarcoma or an Ewing sarcoma, accordingly you plan chemotherapy, which can be done only if you have done a biopsy and achieved immunohistochemistry. Medical legal safety, well, this is what we always preach everybody, that there is no harm doing a biopsy. Even if it is a very, very evident looking benign lesion, your radiologist is reporting it as a benign lesion, doing a biopsy will never, make you suffer any legal suit. Not doing it will always, if it, like in the first example before we started the session, that looked like a GCT came out to be a sarcoma, had to be amputated. At that time, not doing a biopsy could be a medical legal complication. So yes, all of the above is the right answer.
Yes. Moving on to the next question. This is the leaderboard. RR is still leading, but the others are also catching up. Not much difference. Okay. Moving on to the fifth question. Which site of entry for biopsy is correct? So there is a proximal femoral lesion. Which point of entry is correct? Is it red? Is it blue? Is it yellow? Is it green? So you have a proximal femoral lesion. There are multiple entry points which are marked on the image. Which one is the correct site of entry? Is it red? Is it blue? Is it yellow? Is it green? Last 1 second left to answer. Oh, there is a split theme here. The correct answer is yellow, but many have also gone for green. So Michelle, you have to kind of clarify that point here.
Yes. So here, why yellow is the most correct answer is because the green is probably beyond the fracture and beyond the pathology as well. we would not want to enter into the pathological fracture and get callus formation and mislead the pathologist. At the same time, going on the other side of the pathological fracture should be towards the lesional side and not towards the normal side. And you can see the yellow is pointing towards the actual lesion. So when you are going to biopsy through that, you are going to get a sure shot answer. Whereas the green, you are going to go into normal bone or probably get tissue which is in the reactive zone and hence can confuse the pathologist. So that is why yellow is the most appropriate answer here.
A good image to show this point. Thank you for that. So hope that is clarified. Okay, moving on to the next question. I'm skipping the leaderboard for now. What requisition would you make for a biopsy? Will it be A, routine histopathology, blue, immunohistochemistry, yellow, culture and sensitivity, or will it be green, all of the above? So what requisition would you add when you're making a biopsy? And many people have answered correctly, all of the above. So Mr. you can just say the logic behind this.
So over here, like everybody has stressed that there is a dictum that you culture what you biopsy and you biopsy what you culture. So every biopsy that you send has to be cultured. Now, what is routine histopathology and immunohistochemistry? When you do a routine histopathology, they would probably say it is a spindle cell neoplasm. But immunohistochemistry will subcategorize it into what exactly it is. A fibromatosis could also be represented as a spindle cell neoplasm on a routine histopathology, but immunochemistry will tell you what it is. And that is why you have to do all of the above. Culture, histopath plus IHC is one requisition and culture is the second requisition. So that is how you say all of the above.
But do we always write the IHC or is it, as Dr. Manish was mentioning, a reflex IHCs?
So this is, again in tertiary centers, experienced oncopathologists, they would do an immunohistochemistry without saying, but in private setups with multiple laboratories and companies coming up, when you send biopsy, they would do only histopathology because immunohistochemistry costs extra. There are different panels depending on what you are expecting the tumor to be. So it is always advisable that you write immunohistochemistry so the pathologist knows that it is required by you. If the pathologist feels that this on routine histopathology doesn't require immunohistochemistry, then you can avoid it because you're getting the diagnosis.
Yeah, it's a very valid point. The cost factor in a private or a small center, because histopath is a cheaper cost and immunochemistry adds to the cost. So very valid point. So that's why you have to mention all of the above. So moving on to the next question. Short. RR has been displaced and Manish Tahani is now leading. Come on, guys. Last 4 questions you have got to catch up. Let's have a good competition. Coming to the 7th question, when would you do an FNAC? Is it in red in an already treated case to diagnose recurrence? Is it in yellow to confirm myeloma? Is it in yellow to establish tissue diagnosis, or is it in green to do IHCs? Red in an already treated case, blue to confirm myeloma, yellow to establish tissue diagnosis, or green to do IHCs? FNAC is indicated in which condition? Okay, so as the correct answer is in an already treated cases to diagnose recurrence. So Dr. Mitchell will explain the logic behind this.
Yes, so like we had already discussed before, the role of FNAC in bone and soft tissue sarcomas is very limited because FNAC is a cytology test and not a histopathological test. In cytology, you cannot do IHCs, and hence they would just say whether they are seeing malignant cells or not, or to some extent they can even categorize what type of malignant cells they are seeing. To establish tissue diagnosis, again, because the tissue is cytology based, you cannot give a sure shot tissue diagnosis. To confirm myeloma, again, myeloma, you require some panels to be run, so it requires a proper tissue which is only done by a proper biopsy. In an already treated case where you are following up the patient is on surveillance, you have a doubtful soft tissue swelling or maybe a nodal swelling, that time FNAC can confirm, because you already know what the diagnosis was. And if FNAC shows malignancy, it is 99% a recurrence of the same case.
Yeah, that's a fair enough point. So moving on to the 8th question now. We are nearing the end of the quiz. Come on, guys. Excision biopsy is allowed when the lesion is less than 2 centimeter, option red. Option blue, when it's a greater than 8 centimeter lesion. Option yellow, it is less than 5 centimeter lesion. Or option green, never. You never do excision biopsy. So this was covered in Dr. Sandesh's talk. Excision biopsy is allowed when the lesion is less than 2, greater than 8, less than 5, or never. Last 2 seconds to go. And the answer is lesion is less than 2 centimeters. So Dr. Mishra will highlight on this as to why this was the correct answer.
So again, red and yellow were little similar. I put it purposely because to some people it is anything more than 5 centimeters, you have to plan a biopsy and then plan a surgery. But to me, when you have got an imaging done, your lesion could be of X size, and by the time the patient comes to you, it may have increased in size, which may make you, get lesser margins if you're doing an excision biopsy. To me, anything that is more than 3 centimeters should not be excised without a biopsy, and hence a lesion less than 2 centimeters, I will allow somebody to do an excision biopsy, because even in that case, if they do not get margins, my revision surgery will not be a very morbid surgery and patient will not suffer to a greater extent.
Yes. So a slightly controversial one, but in the end clarified that less than 2 centimeters is when you're allowed, because if suppose it comes out malignant, then you have a chance to go ahead and revise your margins. So now, okay, there is a close competition between Manish and RR. Daya is catching up. Manik and Shivam also have a chance. So we are now down to the last 2 questions. So buck up, guys. You just not just have to be correct, you also have to be fast. So coming to the 9th question of this quiz. In a soft tissue lesion, you would biopsy red, the edematous muscle, blue, the center of the lesion, yellow, the periphery of the lesion, or green, any of these 3 sites is okay. In a soft tissue lesion, you would biopsy the edematous muscle, the center of the lesion, the periphery of the lesion. The last 9 seconds to go, and we have got our answer, the periphery of the lesion. 2 have answered any of the above, which is unfortunately not the correct answer, as Dr. Mishra is now going to explain.
So why that is not the correct answer is because the edematous muscle is not a representative tissue. It is just the reaction or the pressure that the tumor is throwing on the muscle which causes edema. And that is why the contrast enhanced MRIs sometimes mislead you. In certain centers where the MRI films or the plates that are given to you only show you, contrast and everything is white. That is not the lesion. Actually, you have to actually have a proper axial T1, T2 weighted image and a contrast image and then take a call. Why the center is not, you already know, discussed by Dr. Vishnu and Dr. Sandesh, that the center is most likely necrotic and will not give you a representative tissue. And that is why periphery of the lesion has to be biopsied, because these tumors grow in that fashion. They are growing towards the periphery, and hence the representative tissue is only at the periphery.
Very rightly said. And this was also covered in the radiology webinar last month, where they said, coronal T1, axial T2, the scans that you have to look for is precisely for this, to know the extent and also to know the site of biopsy. Okay, now we are nearing the end of the quiz. The last question, I will not show the scoreboard for this. I'll show after the last question. When would you need a radiology assisted biopsy? Is it red, superficial and small lesions? Is it blue, bone lesions with no cortical breach? Is it yellow, deep and small lesions? Or is it green, lesions with large soft tissue component? When do we need a radiology assisted biopsy? So lesions with no cortical breach, deep and small lesions, or lesions with large soft tissue component. Last second, and the correct answer is deep and small lesions. Kind of a self-explanatory answer, but still we'll have Dr. Mishra explaining the logic here. for the one participant who got it wrong.
So for lesions with a large soft tissue component, you actually don't require any guidance. You have an MRI in front of you, you know the lesion is so big, the representative tissue, the necrotic zones, they are all in front of your eye, and you can get a good biopsy core. Superficial and small lesions, again, why you don't need radiological assistance, because they are superficial. You can palpate them and you can put in your needle. Deep and small is because they are deep. You do not see them externally, neither can you palpate them. They are small, so that even if you plan on your imaging that it is say X centimeter from the greater trochanter and 2 centimeters deep, this, that, you can plan very well. But once your needle tries to hit the lesion may move, and you may not be into the lesion when you come out, so you may not get a representative tissue. And that is why deep and small lesions is the right answer. Where bone lesions without cortical breach is something that the radiologist is not comfortable biopsying, because their needles are little delicate compared to the J needle, and they may not be able to breach the cortex very easily. Although it is not that difficult too, but it again doesn't require a radiological assistant. You can do it yourself.
Yes. So I think here, actually, all of them, you can use radiology assisted biopsy, but absolute needed is in the yellow option, that is deep and small lesions. And that is why that is the correct answer. So that is the last question. We have come to the end of the quiz. Now let's see the scoreboard for this. In second runner, we have got Shiva ma'am. Congratulations, 8 out of 10. That's fantastic. RR is number 2, 9 out of 10. And there is one person who's got 10 out of 10, Manish Dahani. Congratulations. That is a fantastic show. Manish, if you're online and if you can unmute and if you can just give a small message to others as to how was the experience of the quiz and of the webinar itself. Can we have Manish Dahani on screen?
Yes, sir. Good evening. I'm Manish. Actually, my name is Manish Sahni. Actually, it meant Dahani. D. It is S-A-H.
Okay.
And sir, it was a very well organized, comprehensively covered topic, and especially to the thing which is very important in a routine practice, sir. And even I learned a lot many things from sir during this session.
Thank you, Manish. Congratulations.
Thank you, sir.
Getting in touch with you for the prize money, and please make sure that you attend the subsequent webinars also and share this in your orthopedic group.
Oh, sure.
So handing it over back to Michelle for the conclusion remarks and to end this webinar.
Thank you, Dr. Pratik, for this quiz, helping me out with conducting the quiz in a very, very nice way, keeping everybody on their toes and ensuring maximum participation. And to bring this session to an end, I would thank Sarcoma Education Foundation for this concept of Nurture the Future, our sponsors as well, INTAS, to Dr. Akshay Tiwari for helping me and chairing this session, Dr. Manish Priti for moderating the discussions, and all my other distinguished panelists and speakers who have taken this time out and effort to educate our youth who are probably interested in orthopedic oncology or would be dealing with bone tumors in their routine practice. The aim of this was to make you realize what can be done and what should not be done, and when it is the time to ask for assistance. So you should not be shy to ask for assistance, because like we always say this to everybody, that the first chance is the best chance. A biopsy gone wrong could mean a simple limb salvage surgery ending up into an amputation, a simple surgery with a primary closure becoming a big surgery with a free flap or a local flap, adding morbidity to the treatment. And hopefully all of you who have attended have taken home some message, and this will help you in your practice and your education towards orthopedic oncology and increase your interest towards this field as well. We are always available for any questions. You can go to our website and email your questions or queries. We will have these sessions every Saturday for the whole year. This was our third session. We have 9 more to go. We started from evaluation to radiology and now biopsy. And the further talks are going to be more interesting because now we are starting to deal with tumors and their treatment parts, right from a benign GCT to an aggressive osteosarcoma. So please be, stay tuned. Come every second Saturday evenings. Please spare your time for this and take the best out of this distinguished, list of faculty that we have throughout the year. Thank you, everybody. So on this, we'll probably end the session and see everybody next